Let's discuss some pediatric respiratory disorders now. First is epiglottitis. Epiglottitis. First is epiglottitis. It is characterized by sudden onset high fever and sore throat with saliva drooling from the mouth. It is characterized by sudden onset of high fever with sore throat and saliva drooling from the mouth, and the most common organism which causes is Streptococcus pyogenes. Most commonly it is caused by Streptococcus pyogenes or also by Streptococcus pneumonia or by sometimes also by Staph aureus. Most commonly by Streptococcus pyogenes, and the child sits in a tripod position. The child sits in a tripod position, that is leaning forward. The child sits in a tripod position leaning forward, and on an X-ray, what we will see, let's see an X-ray. Here it is an X-ray where we can see the thumb sign is present. The thumb sign is present. This is a thumb sign. On an X-ray, lateral X-ray of neck, we see a thumb sign, and on laryngoscopy, we see a cherry red epiglottis. Cherry red epiglottis is seen on the laryngoscopy. And what is the treatment? Treatment, first secure the airways and antibiotics requirement is there, mainly third generation cephalosporins are required. So this was about laryngoepiglottitis. There is sudden onset high fever with sore throat, drooling of saliva. Most common cause is Streptococcus pyogenes, pneumonia, and Staph aureus also present. And child sits in a tripod position in leaning forward. And on lateral X-ray of neck, we see a typical thumb sign is there. Laryngoscopy, we see a cherry red epiglottis, and treatment is we have to secure the airway. And the treatment is we have to secure the airway, and antibiotics, third generation cephalosporins are used. So this was about epiglottitis. Now discussing the next topic is laryngotracheobronchitis. It is of infectious origin, most commonly in 3 months to 5 years, and the most common causative factor is para-influenza virus. Most common is para-influenza virus. Most common causative factor is para-influenza virus, and there is history of prodromal symptoms. There is upper respiratory tract infection with hoarseness of voice, hoarseness of voice, there is seal, barking, cough, which leads to, and there is inspiratory stridor. Inspiratory stridor. On an X-ray, a very typical sign is seen. We'll see an X-ray. This is a steeple sign. You can see the narrowing of the. This is a steeple sign. This is a steeple sign. X-ray, very typical sign, that is a steeple sign. X-ray, very typical steeple sign is seen. And what is the treatment? Treatment is supportive, and in no respiratory distress, we can give steroid, oral dexamethasone, and if stridor is present, in case of stridor, we can use nebulized epinephrine. The ratio of 1:1000, or we can also use nebulized or oral steroid. So, there is no role of antibiotics. There is no role of antibiotics. Okay, so this was about the X-ray. The steeple sign is there. Treatment is mainly supportive. If no respiratory distress, you can use oral steroids. Dexamethasone is preferred. And if stridor is there, you can use nebulized epinephrine. The ratio of 1:1000 it is used, or nebulized or oral steroids, and there is no role of antibiotics. So this was about acute laryngotracheal bronchitis. Now we will discuss laryngomalacia. We will discuss laryngomalacia. It is the most common congenital disorder of larynx, and it is most common cause of stridor in infants. What is cause is inspiratory stridor. It causes inspiratory stridor. Why? Because the supraglottic larynx collapses during inspiration. The supraglottic larynx collapses during inspiration, which leads to the inspiratory stridor. This inspiratory stridor, it increases with exertion, like whenever the child is crying or feeding, and in supine posture, and it decreases in prone posture, and it commonly subsides by 2 years of age. In laryngoscopy, we see omega shaped epiglottis. If we see an image of an omega shaped epiglottis, how does it look like? This is an omega shaped epiglottis, typical in laryngomalacia. This is it is omega shape. This is omega shape. So this is laryngomalacia. So this was about laryngomalacia. It is the most common is cause of respiratory stridor in the children. And what are the treatment? Treatment we have to do reassurance, and if sometimes they can be associated gastroesophageal reflux disease, we have to manage it. Nothing else. And if it is not controlled, then we can use supraglotoplasty in cases of progressive respiratory disease. Treatment: if GRD is there, we'll have to manage it, and supraglotoplasty is required in cases of progressive respiratory disease. So this was about laryngomalacia. Now coming to bronchiolitis. It is a very important topic for MCQs. Bronchiolitis commonly caused in 6 months to 2 years, and any first episode of wheezing in an infant is most commonly bronchiolitis. It is commonly caused by RSV virus. Other is influenza, parainfluenza, and adenovirus. Clinical features mainly cough, rhinorrhea, fever. These are present for initial 2 to 3 days, then suddenly progresses to dyspnea, and there is sometimes breathing difficulty. There can be retractions, and there can be cramping. So these are the clinical features, and very common tip is this: the infection is usually associated with infection of a family member. That is, anyone in the family, the father or mother, will have a mild respiratory infection. What is the treatment? Treatment is first of all oxygen support. Warm, humidified, moist oxygen has to be given. IV fluids, if respiratory distress is present, we can use sometimes nebulized ribavirin. Indications can be congenital heart disease, can be chronic lung disease, or any immunodeficiency. Nebulized ribavirin or IV pedi454atric can be used. it is used in preterms or with chronic heart disease or any chronic lung disease of prematurity. Most commonly, like if associated with bronchopulmonary dysplasia, then you can IV pulmonosis. These are the indications. So treatment is mainly oxygen support to maintain the SpO2 oxygen saturation more than 90%. IV fluids with respiratory distress is present. Nebulized ribavirin, congenital heart disease, chronic lung disease, or immunodeficiency. Indications for nebulized ribavirin, or we can also use IV paliumuzab for preterms, chronic heart disease, and chronic lung disease of the prematurity. So this was about bronchiolitis. Now we will discuss cystic fibrosis. Cystic fibrosis is an autosomal recessive defect. It is due to defect in gene which encodes for cystic fibrosis transmembrane regulatory protein, that is CFTR. It is most common mutation is delta 508. Most common mutation is delta 508 mutation. Delta 508 mutation, and there is deletion of phenylalanine residue from 508 position, and the chromosome which is associated is the chromosome 7. Chromosome which is associated with the chromosome 7. So autosomal recessive defect in gene which encodes for cystic fibrosis transmembrane regulatory protein CFTR. The most common mutation is delta 508, and there is deletion of phenylalanine residue from the 508 position, and the chromosome is chromosome 7. What happens with this deletion when there is CFTR? What is the use of CFTR? What is the function of CFTR? CFTR increases chloride secretion into lumen and helps in prevention of sodium reabsorption. So secretions are dry. But with this defect, when there is CFTR defect, this leads to abnormalities of sodium and chloride transport. There is abnormalities of sodium and chloride transport. Now let's discuss cystic fibrosis. Cystic fibrosis is due to mutation in delta 508. It is autosomal recessive, located on chromosome 7, and defect is due to a gene encoding for cystic fibrosis transmembrane regulator protein. Abnormality gene, this leads to dry secretions and abnormality of sodium and chloride transport when this gene is defective gene. So what are the clinical features? Clinical features can be airway obstruction, there can be nasal polyp, there can be recurrent chest infection. Chest infection can be due to Pseudomonas aeruginosa. There can be bile duct obstruction. In heart, there can be right ventricular hypertrophy. There can be exocrine, pancreatic insufficiency leading to fat and protein malabsorption, and there can be diabetes because of exocrine dysfunction. There can be infertility. So these are all the features, and there can be meconium ileus in the newborns. It can be a primary manifestation in the newborns, the meconium ileus. So these are all the clinical features: bile duct obstruction, exocrine pancreatic insufficiency, fat and protein malabsorption, diabetes, infertility, and the meconium ileus. So how do you diagnose it? What are the clinical parameters to diagnose the clinical criteria? So this is the criteria. Sweat chloride concentration more than 60 on at least 2 occasions, 2 CF causing mutations, or abnormal chloride transport, or any abnormal chloride transport, nasal potential difference. These are the diagnostic criteria for cystic fibrosis. That is one of any sweat chloride concentration more than 60. It is diagnostic. 2 CF mutations or an abnormal chloride transport, that is nasal potential difference. That is nasal potential difference is also very diagnostic of cystic fibrosis. And clinical characteristics which are typical for cystic fibrosis, sibling with cystic fibrosis, or positive newborn screening. If on positive newborn screening the newborn comes out to be positive for cystic fibrosis, these can be the diagnostic criteria. Sweat chloride more than 60, 2 CF, remember the number more than 60 because it will be asked in the MCQs. The sweat chloride, what is the number? That is more than 60 millimoles per liter. It is positive. 2 CF, cystic fibrosis causing mutations, delta 508, and the abnormal chloride transport, that is a nasal potential difference. These are one of any. And also clinical characteristics which are typical for cystic fibrosis, sibling with cystic fibrosis, and positive newborn screening. All these criteria are diagnostic for cystic fibrosis. So this was a diagnostic criteria for cystic fibrosis. Now coming to the treatment. Treatment can be multidisciplinary because lots of systems are involved in cystic fibrosis. So let's discuss the treatment part. It is mainly supportive. First is there can be start supportive, then we can give pancreatic enzyme replacement, we can use antibiotics, there will be treatment of cholestasis. There can be, we can use nebulized to loosen up the secretions. We can use nebulized hypertonic saline. We can use human recombinant DNAs, aerosol, and also a very important part will be chest physiotherapy. So these are the treatment part: supportive pancreatic enzyme replacement, antibiotics, treatment of cholestasis, nebulized hypertonic saline, recombinant human DNAs by aerosol, and the chest physiotherapy. These are all the treatment part which can be used for cystic fibrosis. So we have discussed about cystic fibrosis. What are the mutations? Sweat chloride concentration more than 60. It is a diagnostic criteria. To cystic fibrosis causing mutations and abnormal nasal potential difference. One of the clinical characteristics whether typical for cystic fibrosis or any sibling with cystic fibrosis, positive newborn screening is there. And what are the clinical features? There is airway obstruction, nasal polyp, recurrent chest infection, pseudomonas aeruginosa, there is bile duct obstruction, there is right ventricular hypertrophy, exocrine pancreatic insufficiency leading to fat and protein malabsorption. There can be diabetes, infertility is there, and meconium milas in the newborns, and it is due to mutation in delta 508 gene which encodes for CFTR protein leading to dry secretions and abnormal sodium and chloride transport. It is an autosomal recessive, and it is due to this disease is associated with chromosome 7 mutation. Chromosome 7. Now, a little bit about IMNCA classification of ARI. Integrated management of neonatal and childhood illness. Classification of acute respiratory infection of pneumonia, and it is from 2 months to 5 years. It can be divided into three. First is if there is only cough and cold, known fast breathing or chest indrawing. No fast breathing or chest indrawing. What we'll do? We'll do only symptomatic management. Symptomatic management. We will give safe home treatment for cough, and we'll ask him to follow up after 5 days. If there is cough with tachypnea or chest indrawing is there, what is the treatment? Treatment will be oral amoxicillin for 5 days with cough management. We'll explain the danger signs explained and follow up after 48 hours, and if cough for 2 weeks, rule out tuberculosis. And the final is there is cough with stridor. Cough with stridor or danger signs are present. What are the danger signs? Unconscious child, unable to take fluids, or convulsions are present, or persistent vomiting. persistent vomiting is there, then what we will do? We will admit, and this will be given IV Genta plus ampicillin, and this will be fall in the category of severe pneumonia. IV Genta and ampicillin will be given and refer to urgently. We'll have to refer. So we'll refer the child, and this category will be cough and cold, and this category will be pneumonia. So this is about the ARI classification for IMNCI. Cough and cold, no fast breathing or chest indrawing. Cough and cold, commonly cough and cold, symptomatic management, safe home therapies for cough relief and follow up after 5 days. If cough with tachypnea or chest drawing is there, it will be called as pneumonia. Amoxicillin for 5 days. Cough management will explain the danger child to the mother and will ask her to review after 48 hours. And if cough is persisting for more than 2 weeks, we'll rule out tuberculosis. If any child will present with cough with stridor, it will fall into category of severe pneumonia. Or the danger signs are present. Danger signs like unconscious child, persistent vomiting, unable to take fluids, or convulsions are, or if any child who presents with cough with stridor or the danger signs like unconsciousness, persistent vomiting, unable to take fluids, or history or convulsions are there, that will fall into the category of severe pneumonia. We will admit the child or refer the child urgently and will give the first dose of IV Genta and ampicillin. So this was about the AMLCA classification of acute respiratory infection from 2 months to 5 years. Thank you.